this is 12:16, so we'll officially go ahead and get started. Welcome to the April 28th meeting of the Rotary Club of Indianapolis, where we connect and create community. I am President-elect Nick, filling in for President Michael today, who sends his apologies. He has a good friend in hospice care that he is with today. So he sends his best and was trying to make it work today and couldn't quite make it work. So I'm happy to be presiding and look forward to a great meeting. Always good to see the faces of Rotarians. So welcome everyone. For today's moment of reflection, Tim Nation with the Peace Learning Center.
Thank you, Nick. I hope everybody's doing well in this quarantine. You know, quarantine means 40, and I think we've been a little over 40 so far, 40 days and 40 nights. Read about it in the Bible all the time, don't we? Noah, Jesus. Anyway, we've all now have our own experience. So today we give thanks for one another's company during these unique times. Let us give thanks for our families, friends, and Rotarians who help give our world purpose and meaning. Let us give thanks for our healthcare workers who work relentlessly to save lives, and for essential workers who make sure so many aspects of living keep operating. Let us remember those who are sick to pray for their speedy recovery. Let us not forget those who have lost their jobs and businesses. Let us remember those who have passed away so that we may build on their foundations and keep their legacies alive. Our government and leaders are being tested in ways never foreseen a few months back. Guide them to the best decisions for all people. And most importantly, we hope for a vaccine and cure that will help us return with a new appreciation for the freedoms and liberties too often forgotten in our daily lives. Please join me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America
and to the
republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, thank you, Tim. Jamie, do you see, is Aaron Connolly on? Andrew? Sorry, Andrew. Are you on yet?
No, I don't see Andrew.
Okay, so we'd like to recognize visiting Rotarians and guests. I would also like, as Norm mentioned, to recognize new Rotarians of the Rotary Club of Indianapolis. So if I missed someone, I'm just going to go through kind of the order on mine. Maybe give us a quick 30-second introduction. If you've joined Rotary, maybe even in the last 6 months, or are a visiting Rotarian. If I ask if you're new and you're not, then I apologize. But Erin, are you a new Rotarian?
I am, yeah.
Okay.
Hi. Yeah, I live in Brownsburg and I work for Indy 11 Soccer. I'm the Senior Director of Finance. So I've been working at home for a while and anxious to see if we have a season this year or what's going on with that. So.
Wonderful, welcome.
Thank
Mary
you.
Ann? Any other new Rotarians in the last 6 months or so?
I'm new to the organization. My name is Valentine Gidianovo. Just joined maybe it's been a month now that I've been a member, since March. And excited to be a member. I was looking forward to our first face-to-face meeting. Didn't work out that way, but that's okay. I'm glad to finally be on the calls.
Yeah, wonderful. Welcome.
Welcome.
Thank you.
Visiting Rotarian, Alicia, would you like to introduce yourself as a visiting Rotarian from St. Martin?
Hello, everyone. Thank you for having me. My name is Alicia Lake, and I am the president-elect of my club, the Rotary Club of St. Martin, Sunset District 7020, which is the home district of past RI President Barry Ratson. So happy to be here with you all today.
Wonderful, thank you. I've
Welcome.
just based on the name, I would imagine the St. Martin's Sunset Club has to be pretty nice. So I'll have to put that on my list to come visit for sure.
Yes, yes.
Yeah. Other new Rotarians over the last maybe 6 months or so.
John Guy, aren't you a visiting Rotarian?
Thank you for asking. I'm a visiting former Rotarian, having been in Sunrise in Zionsville.
Okay.
John, yeah, good to see you. Mark, you introduce yourself. Welcome.
Thank you very much.
Any other guests, non-Rotarians, guests? Sorry, I'm toggling through a couple pages here. I want to make sure that everybody that's joining us is recognized.
I'm Marianne Whitebrock. I'm an advanced practice nurse. I have visited your Rotarian group at least 2 or 3 years ago in the past at this point. I actually am providing telehealth and helping keep the connection there with a lot of our seniors, a couple work groups actually, and actually keeping their health up. The American College of Cardiology recommends that if you need emergency care, go to the emergency room, because right now they're kind of empty. And they do have room for you, okay? And then the other thing is keep up your routine heart care, because we don't want a surge of unhealthy people having all the terrible risk factors causing all the problems, the cardiovascular problems.
Thanks for being here. Yeah, appreciate you. Emily Sogard is a guest, Mike's daughter. Welcome, Emily. No webcam on the new computer, so no worries. Welcome to the club.
Thank you. Thanks for having me. I'm excited to be here.
Absolutely. All right. Anyone else? I don't want to miss anyone. Any new Rotarians that'd like to introduce themselves? Any guests or visiting Rotarians? Not hearing any. We'll move on. Thank you all for being here. It's good to see everyone. Announcement to talk about civic entrepreneurship grants, Lisa Rawlings with the Central Indiana Police Foundation.
Hello, thank you so much. So we were awarded, the Central Indiana Police Foundation was awarded one of the grants. And so since we are unable to do volunteer work as part of that during the COVID-19 pandemic, what we thought we would do is add the option for our Rotarians to write notes of thanks to our police officers. And so I think I had shared with a few of you in the past, some of our, not all of our officers, I mean, like, for example, the city of Franklin, they are seeing less runs, they're low key, they're not having a lot of challenges or issues with the pandemic. But some of your northern counties, Hamilton County, and then your Marion County officers are really dealing with a lot. One, they're concerned about being exposed and bringing it home to their family. And we have about 30 officers throughout central Indiana that are positive right now with COVID-19. So that's also affecting staffing with some of those departments. But the officers are also dealing with a ton more alcohol-related calls and domestic violence. And as many of you have probably seen, on April 9th, IMPD lost an officer, Breanne Leith, 24 years old, in a domestic violence call. And those are some of the most dangerous calls that our officers can face. Pretty consistently, most of our deaths of police officers come from domestic calls. So they're just in a lot of stress right now. And so what I was asking if folks would like to do is just write a note of thankfulness for our officers, and then they could send those to me, and then I will distribute those to the most hardest hit areas, specifically IMPD and some Hamilton County officers. And so if you'd like to do that, or you could also email me a note and I could fold that, put it in an envelope and address it to an officer. So maybe that might be the easiest and quickest. My email address is lisa@ci, you know what, actually I'll type it in the group chat. I'll just do that. That'll make it easier. I'll type it there. But So what the grant is going to allow CIPF to do is we are ordering some PPE equipment. Some of the departments do not have staffing that is able to find the equipment. And so myself and one of my board members have been focusing a great deal on finding equipment that has already crossed customs and in-state, so we can provide masks, gloves, gowns, and some of those shields or eye protective glasses that they can wear. So we're ordering some of those materials and getting those to the departments that need them the most. We're also providing hot meals for our officers. And then for those officers that are COVID-19 positive, we're providing grocery gift cards. And so the $1,000 of this entrepreneurship grant is going to be used towards funding those activities. So thank you very much. And again, I will put my address and my email in the chat area so that you can copy that if you would like to help write some notes to some officers.
Thank you, Lisa. Appreciate you sharing that, and thank you for all the work that you and your team are doing. Real quick, talking about next week's program here on Zoom. Please join us next week, same time, 12:15. We'll hear from Mel McMahon Stone, who is an entrepreneur, radio and television personality, local business advocate, and co-founder of Indiana Originals. Mel travels the state to help local business owners find the resources they need to be successful and helps consumers find local Indiana-based businesses faster and easier. Mel will talk to us about the impact of COVID-19 on local businesses and how we can continue to support them as the state begins to open. So next week here on Zoom, Mel McMahon Stone. So we look forward to that. Introduction of Dr. Carroll for this week is Stacy Robinson with the IU School of Medicine.
Thanks, Nick. Yeah, and thank you so much. I was so glad that Dr. Carroll agreed to come be with us today and answer our questions. It's my pleasure to introduce him. He's one of many outstanding faculty members at the Indiana University School of Medicine. He's a contributing opinion writer for the New York Times, and he has brought a voice of reason based on science about COVID-19 to both New York Times readers and to the 5,000 Twitter followers who follow him at Aaron E. Carroll. Dr. Carroll is a professor of pediatrics and associate dean for research mentoring at Indiana University School of Medicine. He is also vice president for faculty development at the Regenstrief Institute, which is an internationally respected nonprofit medical research organization that's associated with the School of Medicine at IU. He earned a BA in chemistry from Amherst College, an MD from the University of Pennsylvania School of Medicine, and an MS in Health Services from the University of Washington, where he was also a Robert Wood Johnson clinical scholar. His research focuses on information technology to improve pediatric care and areas of health policy, including cost effectiveness of care and healthcare financing reform. He is the author of the Bad Food Bible and co-author of 3 additional books on medical myths, which are really good, actually. Have a chance to take a read them. In addition to contributing to the New York Times, he has written for many other major media outlets and is an editor-in-chief at the Incidental Economist, an evidence-based health policy blog. He also has a YouTube channel called Healthcare Triage, where he talks about health research and policy. So now I'll turn it over to Dr. Carroll so he can answer questions and share information about COVID-19. Thank you.
Thank you. So I don't know the best way to organize this, so I'm just going to talk for a few minutes, and then basically if people just want to come off mute and ask questions, that'll be fine. So I'm a health services researcher, which means that I've spent pretty much the last 17 years, mostly doing research on how we can improve the access, quality, and cost of the healthcare system. I don't do research on like patients or drugs or diseases. It's much more of like, how do we make the healthcare system better? And this pandemic has tested us, mostly because while we spend an enormous amount of money on healthcare, we woefully underinvest in public health. And we've skated for some time because of that. But this has laid bare some of the gaps and the holes in the public health system, which are going to make things difficult moving forward. The most common question I get asked right now is when are we going to end this? Like, when are we going to go back to normal? And the short answer is we got to redefine normal, at least for a period of time. But even then, I think most people are asking, like, when can we stop sheltering in place? And so the vast majority of experts around the world have coalesced around a couple principles. And there's not much debate on what these are. This is the way that we need to sort of measure things and get steady before we could actually like start to open things up. And I should say again that that this is how like we take the next step, not how we like solve any problems or do anything else. But really the first thing is that we have to know that the healthcare system is not going to get overwhelmed. And I should also say, these are going to be decisions made at local or state levels. The idea that the United States should be measured on one big metric is ridiculous. Clearly, some parts of the country are going to be more affected than others. And clearly, some are going to be more capable than others of ramping up the infrastructure necessary to move forward. So when I'm giving sort of these metrics and what we really need to think about, it's important to know that we're talking about Indiana, or even we could break it down into cities, but we're not talking about the country. The country is an enormous place where there's a huge variety of differences. But in general, any location, first of all, needs to know that its hospital system is not going to get overwhelmed. That is the reason we all went to sheltering in place. It was because we wanted to avoid Italy, we wanted to avoid Spain, we wanted to avoid what's going on in New York, where very rapidly, if we allow things to progress at an exponential level, the number of new cases showing up can easily overwhelm the healthcare system. The good news is Indiana's done a pretty good job of avoiding that. In large parts of Indiana, we've probably peaked, or we're there, or we passed it, in which case we can start to relax a little bit. Other parts of the state are sort of still on an upward climb, but even then, we have enough statewide capacity that we're probably okay. So first metric, likely met. Second metric is that we need to see cases coming down significantly. Some experts say at least 14 days of decline, but the number of days is not as important as sort of how much it's come down. The bottom line is we need the number of cases to come down such that the number of new cases appearing every day is a manageable number. We can't have more cases than we can track, because that's, again, we spiral out of control and we'll wind up here again. So we have to wait until the number of cases have come down enough that we believe we've got a handle on this and can maintain it in the future. And that's what the next two criteria are. One, we need to be able to test everyone with symptoms, because we got to know every disease. We cannot miss many cases. We're going to miss some because of asymptomatic people who don't look sick, but nonetheless are infected. We know that. Because of that, we can't miss anyone with symptoms. So anyone who's sick at all needs to be able to get a rapid test. All healthcare workers and first-line people need to be able to get a rapid test. We got to have enough testing so that we can move forward. That is likely larger than the amount that we're doing now. And of course, that will also correlate with how many new cases are appearing. If we exit earlier and have a lot of cases every day, then we need a massive number of tests in order to keep on top of it. If we wait until the number of new cases every day is lower, we probably don't need as many tests in the near short term in order to do it, but they go hand in hand. But the bottom line is you got to have enough testing to identify every case that possibly could be there. And then the last criteria is we need to be able to do contact tracing and isolation. We have to be able to track down with every case, where did you get it? Who were you exposed to? Who else might have been exposed by you? Find those people, quarantine them, and then test them if they get symptomatic. That's an enormous public health infrastructure. There are probably like 3,000 people in the country right now in public health departments that are dedicated to contact tracing and isolation. We need probably hundreds of thousands. Like, this is going to take a couple $1 billion alone just to ramp that up. The good news is a couple $1 billion these days is chump change. We are blowing, $20+ billion every day we are nationally in lockdown. It makes no sense to get stingy about a couple $1 billion for contact tracing and isolation. It really doesn't make sense to be stingy about $40 billion for testing either. These are things that have to happen in order for us to maintain sort of a status quo where we don't let this rage out of control and have to go back into lockdown. And that's the big concern, is that if we exit, and when I say we, meaning any location, if we exit and we can't keep a handle on it, once it gets above a certain number, the only tool in the toolbox is what we're doing right now. It's going back into sheltering in place. back into social distancing and watching and waiting until we can get a handle on lowering the curve again and coming back down. Nobody wants to do that. The economic cost is devastating. And so as much as possible, it behooves us to get as much in place and be prepared so that we don't need to do this again. And that's where I'm going to stop, because I'm sure there's plenty of questions and I'd rather talk to people's concerns or questions than keep going. So I'm going to stop. Come off mute, ask anything you like.
So let's, thank you. And I'm sure there's lots of questions. So use the raise hand tool on the, in your reactions. I can call on individuals, so we try to keep it as focused as possible. If you have a question that you would like to type in the chat, I can get to that, or you can acknowledge that you have a question in the chat box and I can call on you there. So I will try to manage through this as best possible. So Norm, I saw your hand first.
Thanks. My fear, Dr. Carroll, is that once we get a vaccine, we're all going to congratulate ourselves for having beaten coronavirus at a terrific cost, but we'll tell ourselves that we did great. And the next one that comes along, we won't be any better at.
Yeah.
What can we do? What should we do either now or once we beat coronavirus to prepare for the next one? And how do we get the politicians to actually do what they need to do? Because it sure looks like we don't wanna.
Yep. So it's an excellent question. I mean, the good news from a human nature standpoint is that there's a reason that many of the Asian countries are doing well at this when we have failed. And that's because they've been through this before. When SARS hit in like 2002, 2003, they were hit hard and they were caught off guard and things were very bad, but they learned and they set up all of the infrastructure that we're now seeing in South Korea and Singapore and Taiwan and Hong Kong. We did not get hit by SARS. And so we learned nothing. Neither did Western Europe, which is why they're also been totally caught off guard. But hopefully we will learn something this time around and we will now have, public health departments that are prepared to do contact tracing and isolation. We will recognize how quickly these things can rage out of control once we hear about them. You'd be hard pressed to find people who were consistently panicked in January. I mean, truly, almost everybody was caught off guard in the United States. And we can play blame now and try to point fingers, but January was almost a loss. Like, nobody was really that concerned. Very few people in the United States by what the magnitude of this was. In February, more people. By March, if you weren't getting on board, yeah, fine, we can start talking about quibbling. But I think, hopefully, having been through this once before, the next time we hear about a disease which is starting to come up in another country, we won't wait. We'll be a little bit better prepared. We'll be more aware that we might need to, talk about travel restrictions. We might be, better prepared with testing and quarantining people as they arrive to making sure that they're not spreading it, which is what most of the Asian countries did to keep a handle on this at the beginning. But I'd also caution you, our learning is not done. The likelihood of us finding a vaccine soon and being done with this in the near future is incredibly low. I think we're going to be under a very different way of life for at least a year or two. And hopefully it'll look more normal than what we're doing now, but it will not look like normal. And we all may learn something from that. I mean, I think, we all may be a little bit more aware of good hand washing is massively important all the time. Avoiding large crowds when you don't have to, probably a good idea. Business travel, only if it's really, really necessary. A lot of people, I canceled 8 trips in the last 2 months because of business. And I'm questioning now, why did I need to go on any of those? Because most of them I can do the meeting like this. Why was I doing that? I think we're going to see changes like that, which will leave us perhaps better prepared the next time around. I think the world is going to look a lot different now, from a lot different in 2 years than it looks right now. And we'll all have probably changed some of the things we do to adapt.
How did
Question in the chat, Dr. Carroll, can you talk about Sweden's approach.
Sure.
We have some fascination by Sweden's approach. Can you speak to that?
So Sweden is getting a lot of play in the press, but it's important to understand that Sweden is making a very public claim that they are not instituting shelter-in-place lockdowns and instead relying on voluntary people make their own decisions. Having said that, the vast majority of Sweden is engaging in social distancing and sheltering in place. Like, movie theaters are closed. Like, it is not like their business as usual. They are voluntarily making an enormous amount of restrictions as opposed to sort of asking businesses to do that. It's also important to know Sweden is massively helping their population, and they are much more socialist than we are. And so it is not as if Sweden is let's see what happens. Having said that, they are not engaging in what most of the rest of Europe is doing. And so we're watching. It's not clear yet how that's going to work. Sweden has been like sort of drifting up, and it looks like they might be peaking, but we can't tell yet. And so it's an experiment in what asking people to voluntarily do, how that may be different than imposing more rigid structural changes on people. But, Sweden is very different than the United States too, in many, many ways. And they are much more collectivist than we are. And so I would expect that they will act as a population very differently than Americans will. So I'm still not even sure how that would play out in America, but it's another data point and it is something to watch.
I'm going to transition into the segue from Kimball Richardson to, based on that, what you were talking about. He said, so far we've been quarantining voluntarily. Do we have a way in Indiana to forcibly make people quarantine? Kimball works in healthcare and is aware that some individuals may not be compliant if they are COVID-19 positive.
Yeah, I mean, like the countries that are doing this really well have massive fines for people that violate them. Like if you are known to have COVID and you leave your house, it's like 10 grand. And people pay it and they get caught. And even more restrictive countries, it's like if we're telling you to be on lockdown and you leave, there can be, Singapore is also like $7,000 or $10,000 if you're literally caught like having coffee in your neighbor's house. So we are resistant to that, and I get it because forcibly removing people from their homes and isolating them would never fly here. It's just not gonna. I think even forcing people to isolate just on the idea of a quarantine is going to be very, very difficult. However, it depends how bad things get. Usually I think they're going to do the least amount that we need to in order to achieve the result. And Indiana's been achieving the results we would like to see for the most part with respect to getting a handle on the outbreak with the measures that we have in place. So there's really no call for more restriction. Now, if we were failing, and we could say we're failing because people are not listening, I expect that restrictions would increase. But in general, I think American governments are going to go for the least intrusive amount possible. It's just that we got to a point where this was starting to rage out of control. And I think in areas, it is still not known if we got this under control. This was the tool in the toolbox. And you've seen differences. I should also note that even in the States, even in states where the news will talk about they're not doing it, states, again, are not one thing. Florida has not really ever put like some high level, really strong levels at a high level, but many cities did. In Georgia, the governor has lifted a lot of restrictions, but then you got mayors going on TV going, I don't care what the governor says, we're staying sheltered. So there's, listening and listening. And I think that, at an individual level, the vast majority of Americans are doing what we want them to do. There are going to be people who don't, but they represent a small percentage. And I think that we're seeing in most places, things go the way we would like because people are doing what we need them to do.
I'm happy to continue reading them. I'm also happy to acknowledge folks that have questions. Even if you put in the chat, just I have a question and we'll get to that. But from Lisa Rawlings, Dr. Carroll, could you talk about from a scale of 1 to 10 of severity, with 10 being the worst, what is the seasonal flu, what is COVID-19, and where does SARS fit into that picture?
So okay, let's look at it this way. So the last time that we saw a virus which was this potentially damaging that was this infectious that we had no natural immunity to and no treatment for was Spanish flu 100 years ago. Like nothing has been, we've had flu pandemics, but we have a natural immunity to the flu, and we've got some vaccines. So, you know, people quibble all the time like, oh, the flu vaccine's only 60% effective this year, but that's way better than nothing. Like I've written many columns on like, we can quibble about whether 60 or 80% effectiveness is, but the difference between like 60% and none is what we're seeing right now. This is probably more dangerous than the flu in terms of its lethality generally. It's more infectious than the flu. We have no natural immunity to it, and we have no treatment for the most part, and we definitely don't have a vaccine. This is way worse than the flu. Now, again, I've written more than one column urging people to take the flu more seriously because the flu kills tens of thousands of people in the United States every year, but it's over like 8 or 9 months. Like it goes like this every year. And only when it starts like this, we panic. That's the pandemic. But for the most part, the flu is like this. COVID has been like this. You know, we've had 60,000 deaths in like a month and a half. That is like nothing. And that's sheltering in place. Like flu deaths are low this year because we're sheltering in place. Like the stuff we're advocating people do to avoid coronavirus is the same stuff I'd advocate to avoid the flu. Wash your hands, avoid people sick, don't get it. So it's like all good advice, but like we've managed the flu to a reasonable, predictable level year to year. We cannot do that with the coronavirus. Like if we didn't shelter in place, let's say New York hadn't, I can't describe like how much a week more might have, another week of exponential growth would have been devastating. Like when we got off the exponential growth in the United States, we were like, I remember I tweeted at one point, I'm like, okay, the curve right now says 10,000 deaths a week, like a week from now. And then a week after that, it'll be 10,000 deaths a day. We got off that curve. But if we stayed on the curve one more week, we would have gone off from 10,000 deaths in a week, which is like a week, 2 weeks ago, to 10,000 deaths a day. Like it just goes like this. And flu does not. If flu did, we would be reacting like this. Flu is a nice, slow, manageable rise and fall. And we worry about it, and we should do a better job. And I wish more people got vaccinated, and I wish we took it more seriously because I'd like to see 10,000 deaths, not 40,000 deaths. But it does not rage like this. It would not blow through the population like it has in a number of countries, like it has in New York. It's way worse, way worse. Now, having said that, if we ever do get to herd immunity, we won't be nearly as worried, and you'll see the thing it'll go down because then it'll be harder to transmit, and you know many people are fine when they get it, and so the numbers we won't worry about the outbreaks. If this was a slow, steady thing like flu, we wouldn't do this. The problem is that if we weren't engaging in the social distancing we are doing right now, it would not look like flu. It would look like a horror show if it doesn't already.
Is there one for Mary Ann and Kate? I'm going to kind of combine their questions here. Is there currently more than one strain of the virus? And could you talk a little bit about the possibility of the virus mutating?
So I think there's a general belief that there are like 2 strains active in the United States right now, a different one on each coast. It's important to understand viruses mutate all the time, all the time. Tons of mutations make no difference at all. Changes like a base pair in the DNA, it doesn't even notice, it makes no difference. In fact, that's how we're built, because if every base pair change in us resulted in major changes, that's cancer, we would die, or something else. So most changes don't matter at all. And even some changes that don't necessarily make it worse, sometimes they make it better. Like it becomes less lethal, it becomes less infectious, it dies because it becomes unsustainable with the virus's continued existence. What we worry about are mutations that change the way that affects infectivity or its power to hurt us. So if it gained the ability to hang on harder in the lung or avoid the immune system, that would be a problem. Lots of viruses don't do that. Like you get chickenpox as a kid, you never get chickenpox again. We get lifelong immunity for the most part. You get, tetanus, we rebooster you like every 10 years. it lasts about that long and we need to. Some things we don't get great immunity to. The flu is terrible because the flu likes to mutate in ways that lets it avoid our immune system. That is why we need to change up the shot every year. That's why, you know, just because you got the flu last year doesn't mean you're not going to get the flu next year, because often it looks very different. That's flu's superpower. At this point, coronavirus does not appear to be doing that. The mutations that have occurred that we can measure in real life don't appear to have made much of a difference. And coronaviruses in general don't appear to mutate, because there are lots of coronaviruses around. They don't appear to mutate in ways that do that avoid the immune system. Having said that, we don't think that people in general build up lifelong immunity to coronaviruses. You know, SARS, it looked like people were well immune for like 2 years. And we contained it and got rid of it. It's eradicated, so nobody worries about it. We don't worry about making vaccines, but it wasn't the lifelong immunity. We don't know what people are going to get from coronavirus. We just don't know from this one. And so that's why some people are worried, and we don't know how well the vaccines are going to work and everything else. So to answer the question again succinctly, there have been some mutations, but not in ways that would cause us to worry yet. And certainly people are watching that like crazy, but you don't need to assume that every virus finds a way to mutate to make it worse. You know, that doesn't happen commonly for the most part.
You were talking about the flu vaccine. So what's the current biggest barrier to the development of a vaccine or even an immunity or antibody test?
The biggest one to a vaccine is we've never made a coronavirus vaccine before. We just haven't. We've not had the need. SARS, they contained and eradicated so fast it wasn't a big deal. MERS, the same thing. So, and the other coronaviruses cause like colds, so nobody cares. So that's, I think, the bigger worry is that like we just haven't done it. And there are viruses out there diseases we'd love vaccines to that we haven't figured out yet. HIV, you know, Ebola, it looks like you got a vaccine. That took 5 years. But again, the good side of it is like, I don't think you've had this many scientists working on one issue as fast and as hard as they have perhaps in the history of man. This is an existential threat kind of thing. People all over the world are massively putting every resource they have into this, partially because we need it, and partially because there's a massive, massive financial windfall on the other end of this. Like, believe me, the company that invents the vaccine is going to do fine. Like, there's going to be 8 billion customers for this thing. So it's there's a lot of things aligning towards, you know, more resources being poured into this and more people looking at it than almost anything else going on. And so that would give me some optimism. And we don't have a reason to believe it would be impossible. We just haven't done it before. But, you know, there are lots of things we haven't done before that we can. We know how to make vaccines in general. So, you know, hopefully they will get on this, but it will still take time. And even when they find it, making 8 billion of something is going to take a long time. Like, it's not, they cannot just churn that out. You know, making and distributing, even in the United States, 300 plus doses of a vaccine is not going to be a small lift. That's a heavy lift. So there's a lot of things that have to happen to make this work. Now, with respect to testing, I swear to God, I have no idea. Like, this is the biggest bafflement of all. I cannot figure out why we cannot get our act together on the testing. Like, just ramp it up. Like, this is when, like, put companies on it. You spend the money, get the resources. We know how to make the test. That's just a scaling issue. Do it. Do it a month ago. I don't know what's going on. Serological testing will take longer, but we'll get that done. But that's almost secondary to what we really need. What we need right now, you know, really quick PCRs testing, although that's going to be more difficult. We can get to antigen testing, which is going to take a little more time and will be faster and cheaper. So we should be investing in getting that done like now. I don't understand. Like, that, I get why we don't have a vaccine. I literally cannot figure out why we cannot get our act together nationally on testing. That's baffling.
And that's a great segue to the next question from Bill Batt. So even if we do have the capacity with more testing and contact tracing, how do we open up without vaccines and immunities?
Well, we can't. I mean, I would love to have a vaccine to open up, but, like, again, knowing that's 2 years away, we can't do that economically. Like, you know, I'm on like the we need to stay in sheltering in place side longer than some people are, but nobody says stay in sheltering in place for 2 years. Like that's not going to work. So our best bet, therefore, is to suppress this as fast and hard as we can, get to a manageable level, and then manage it. You know, keep it so that the infection's still there, but at a manageable amount. That is the game plan in South Korea, in Taiwan, in Hong Kong, until recently in Singapore. It's what China would tell you they're doing, but I don't know what's going on in China as well. But most of the Asian countries that we can see, that's what Australia is doing. That's what New Zealand is doing. You got to get it down to a small enough number and then rigorously find and keep everyone who gets infected apart and quarantined. That's how we beat these. That's how we beat these kinds of things. That's how we contained and beat, you know, SARS without ever coming up with a vaccine, and MERS and Ebola. It's like we have to just keep squashing these things back into the ground and then, you know, finding a way to avoid things. So we can do this. It will require us to make some sacrifices and it will be difficult, but we can go back to a more normal way of life if we do the right things, build the right infrastructure, and wait long enough to get a handle on this. But it's politically difficult. And again, I cannot for the life of me figure out where the roadblocks are in testing and in building up some of this public health infrastructure.
So from Tim Nation, it looks like Indianapolis has about 5,000 known cases, but similar sized cities, Louisville and Cincinnati, have just over 1,000. Could you speak to the differences between you know, cities similar size within a fairly close geographic area?
So first of all, I caution everybody on those things because like the testing rates differ. The number of cases is very dependent on the number of tests being performed. I don't know how many of you watched Chernobyl, like the HBO series, but there's this unbelievable scene where like they go and they measure how much radiation there is, and they get like, how bad is it? And the guy's like, we're reading 3.6, and he's like, 3.6, that's not that bad. And they're like, that's as high as it goes. It was at like 1.5 million, but they could only see 3.6. If you only do a little bit of testing, you're only going to find a little bit of disease. If you do a ton of testing, you might see a lot more. So, you know, the testing rates in those cities differ too. So I wouldn't necessarily say that the outbreaks are the same. Having said that, you're going to see differences based upon clusters and outbreaks and where they are and how people live and how much they come into contact with each other. I mean, New York is having a problem because they all live on top of each other. I live in Carroll, Indiana. I take a walk every morning for an hour and I don't see another human being. It's incredibly easy to socially distance. Indiana does not look like New York. Louisville doesn't look like Indiana. Like, it's just, there's some differences in how those are there that it's, and also it depends how, you know, how much business travel there was, how many cases got seeded originally, how many people were bringing it from other places, how well and quickly those places went into social distancing. There's some people that are arguing that if New York had gone into quarantine a week earlier, they could have spared themselves like 60% of the deaths. A week makes a huge difference when you're talking exponential growth. So it's also dependent on how panicky people got, how much they started the social distance, how much they listened, which is why, again, you're going to see, I think, a lot of geographical variation in how people are handling this and how it's going.
From Kyle Defer, we talked about, you know, how do we know that we're on the downslope? We're daily increasing the number of tested, so the number of positive cases is going up. We've also recently started counting presumptive death cases, which has increased the number of deaths too. Yep. Is this why we're not seeing any slope graphs for Indiana?
Oh, I think there are slope graphs. You can find them. The State Department of Health has them. Regenstrief Institute has a whole testing thing up where they're like watching every test in the United States, in Indiana. So the reason I think people are feeling reasonably comfortable that we might be peaking is mostly looking at hospital data, because, you know, hospital admissions and deaths are much harder to miss because like the denominator is known. It's not as like influenced by testing, like how many tests are we getting. So those have been peaking in lots of Indiana and even perhaps trickling down a little bit, which now deaths are lagging behind because deaths lag. So the first thing we're looking at is hospitals, and hospital admissions and ICU admissions are looking much better. And that's the first good news. testing, while we're increasing the number of tests, the percentage of people that are turning up positive is like, it's looking in the right direction. So that also gives us some hope. But you should not hear from anything that I'm saying like, open for business, we're good. Literally, the day after the peak is the second worst day. It's not good, it's just good, better. And so we don't just have to peak, we've got to really come down. This is, I think, like not my last comment, the one before, like we really have to come down. And unfortunately, lots of countries in Europe are doing this. They're not coming down. So it may take us longer to get to manageable levels than we would like. Of course, that gives us more time to ramp up testing and perhaps get our everything else in gear, but we got to act. And so I'd say that there's reason to believe the social distancing is working and we may be over the hump, but that should not be taken to mean that like good news, open for business. We got to ride this out until we really get this to more manageable numbers.
Question about masks. Could you talk about the necessity of masks, in particular fabric masks? A lot of conversation around masks. So what's the benefit or any cautions around masks?
So people are wearing, too many people think we're wearing masks to protect ourselves. You may get a tiny, like single-digit percentage reduction by wearing a mask, That's not why that's not why most people are advocating masks at this point. Now that's why healthcare providers wear masks. Don't get me wrong, but that's because there are massive exposure situations where people are like coughing into their mouths. That's why they got the N95s. That's why they got like surgical masks. They are protecting themselves. The rest of us, the cloth masks, that's to protect others from us. So that's a societal compact of there's too many people who don't know they're sick. And if they're coughing, breathing, exercising, singing, whatever, they could be expelling virus. We got to stop that. If we put a cloth mask on, we make it less likely that their aerosolized particles get out very far. So the reason I think the guidance has changed on masks is because the calculus changed. We went from thinking very few people have this, you're not really protecting yourself, why bother to wear a mask for that reason, to way more people have this than we thought. Anyone could have it. We all need to wear masks to protect others from us. I think you're going to see a lot more mask wearing than you used to. I think that that's part of, again, the collective response, that if we're going to go out, and it's also going to be part of the making people feel safe. The other flip side of the how do we restart the economy is not just opening the businesses, it's convincing customers to go back out. My wife is scared. Like, I'm not totally feeling good about this. They could open up businesses tomorrow. We ain't going. Like, my job is still sheltering in place. I mean, they're like, people are not going to go out. People are going to go out when they feel safe. Part of the feeling safe is going to be collective action. Like, we're all going to wear masks. We're all going to do stuff. So I think you're going to see a lot more mask wearing than you used to, because that's going to be part of we're all in this together. This is how we protect each other. This is how we can all start to go about our business once again.
Norm, I'm actually going to skip yours and save it for last so we can end on a note related to the silver lining of all of this. So from one of our near elderly or elder statesmen, however he wants to look at it, Judge Fisher, will the elderly likely have to shelter in place until a vaccine is found?
My God, I hope not. So again, it's going to be very dependent on how much community spread and disease is out there. This is all about risk mitigation. We can't reduce the risk to zero. Can't be done. Like until we get a vaccine. So our goal at that point is to say, like, how much of a risk are you taking on and how much of a risk would it be if you really got sick? So those who are most at risk, the elderly, the immunocompromised, people with chronic conditions, the bar for how safe it should be to go outside is going to be higher. So when we start to loosen restrictions initially, there may be, a certain number of cases. And we might say, like, there's too many out there for people who are really at risk to come out. But the goal would be that if we really do a good job of this, and we can do contact tracing and isolation, and we can suppress this down to where, say, in Indianapolis, new cases are very low, and other countries do this, it can be done, then the likelihood of you being exposed, if you're careful and and you go about your business and you still observe reasonable social distancing, will be pretty low. Go ahead. But it will be later than it will be for many other groups because where we need to get to say, like, you're at a reasonable risk for the elderly is going to be higher. So it'll probably take longer, but I really hope it's not till we get to a vaccine. I would really like us to get a better handle on this at local levels long before then.
Could you talk a little bit about treatments? So opportunities for general treatment, no matter the cause. So maybe not the vaccine, but some general treatments for this that have been successful.
It's not the cost. I mean, the cost is like incredibly, I mean, the drugs that they're trying out are like generics. I mean, it's not the cost. The problem is that, one, even the little studies which show a benefit, it's important to understand we're talking about people who are like on ventilators in the ICU. Like, it's not, hey, go about your business, we got a treatment. It's, okay, if you're on a ventilator, we might reduce your chance of dying a bit. That's not going to change how most people live. It will change some of the economics of this in the sense that like we can prevent death, but like you'll still be hospitalized on a ventilator. Like this is still bad outcomes. The bigger problems are that these drugs have side effects. These are not like we're putting lots of drugs into your veins and this is not like taking an aspirin. And some of the data show that the side effects may outweigh the benefits because the benefits are pretty small and in small populations. So there have been really, part of my job at IU is I review every paper that is written on treatments for COVID every day that comes out. And then the ones that look good, I like flag them and I write summaries for like the CTSI website. And I'm telling you, there's nothing there yet. Nothing has been proven. Scientists are not really behind any of these yet. We don't really have many treatments for viruses. Like the only treatments we've got for viruses for the most part are like HIV, which again took decades. I mean, we didn't invent that like that. Like it took a long time to get HIV therapy. Tamiflu for influenza, again, because we fight that every year. Like we don't have a ton of stuff on the shelf that does a great job of fighting viruses for people in the outpatient setting. We have some stuff we throw against the wall when people are near death. That's not the same thing. So we just don't have much yet.
This is going to be the last two questions. Could you talk a little bit, what do you suspect the governor is going to tell us on Friday when the current stay-at-home order is due to expire?
I think that there's a reasonable chance that they'll extend it just a bit more because I don't think we're quite there yet. If not, then I would expect that he will at least announce a date for when we might start to ease restrictions on certain businesses at certain levels for certain people with certain precautions. I am not the governor, so it won't be my decision. If it was my decision, I think I'd hold this in place for a bit longer because again, we're peaking, but we're not down. Now, he may say, we're going to do this in 2 weeks as long as we continue to go down. Okay, let's keep watching. But my biggest gripe with politicians nationally is they just keep grabbing dates out of the air without benchmarks for what we need to achieve for that date to be real. I'd much rather see that. But again, I think that the public health department and the governor have Indiana's done a reasonably good job. Like this is not, no one's pointing at us nationally and going like, look out Indiana. We're part of that Midwest I'd also say we're part of this Midwest consortium. So I think we're making decisions together. So I wouldn't expect any real surprises. It sounds like most of us are trying to follow the same benchmarks as the states that are surrounding us. And so maybe they come up with like a plan that they're implementing. If we look like Ohio, it's going to be something similar, I think, where it's going to be like, if we meet certain benchmarks, then we'll come out of this.
Great. Last question from our club optimist, Norm Melzer. Could you talk a little bit about the silver lining? The self-isolating benefit in terms of reduced costs and flu. If there is a silver lining, how long will that benefit last? Take us out on a
okay. I will say this. I will answer this question, but no one should take from this for me to that I'm minimizing the horrific cost of what is going on out there, both from a human perspective in life and disease, and also an economic. It's horrific. Having said that, there were things that we would like to change about the healthcare system that looked inevitable that are now happening that I'm pleased with. Telemedicine, huge benefit. Like we just couldn't get our act together to figure out how to pay for it, how to do it. It's all the rage now. I don't think that'll change. We are figuring out how to do things at a distance in a safe manner that before we would have refused. Again, why did I do all that business travel? Like I don't need to. I'm also realizing like I can give talks like this all over the country without ever leaving my home. maybe we'll get better at that. Maybe we'll get, better at providing different kinds of education or different kinds of ways of learning for students. And also it's like maybe we will develop lifelong habits that are good for disease prevention in general, especially infections. Infections kill a lot of people still. And if we all develop better habits that keep that limited in the future, especially for things like flu, so much the better. We can all benefit from that. And, I think, there are lots of studies coming out. This is good for pollution. This is good for the environment. Pollution is coming down all over the place. I jokingly saw on Twitter, like everybody's getting like 3 weeks to the gallon now in their car. So we're using less gasoline. It's like there are things that you can point to. Food delivery has gone way up. It's like, lots of options. So, and I've also, there's also been a collective level, I think, of spirit and community that sometimes is lacking. The news likes to highlight our divisions and focus on protesters or people who are very much against it. But the vast majority of Americans are taking more of a, like, we're all in this together approach, and we're all doing this to benefit each other, not just ourselves. I think there's plenty of good in that as well.
I appreciate that. As a closing there, I will say that there's not too many groups that do spirit and community better than Rotary. So we really appreciate you being here and sharing your knowledge and information. It was extremely insightful and extremely helpful, and I'm sure that everyone, in fact, we had one chat that said, I had to leave. I wish he could talk every week. So both informative and entertaining. So we really appreciate you being here, Dr. Carroll, and we appreciate everyone that joined the call. We need to start to wrap it up here, but we really appreciate everyone being on the call. We hope to see you next Tuesday to hear from our speaker related to small business and the impact of small businesses and how we can support small business. So thank you again. Guests, thank you. If you're interested in joining Rotary, please reach out and let us know. You can find information on our website at indyrotary.com. Otherwise, we can all unmute, if you like, for the saying of the four-way test of the things we think, say, and do. First,
is it the truth?
Second,
is it
fair to all
concerned?
Third,
will build goodwill and
better friendships.
And fourth,
will be beneficial to all concerned.
Thank you all so much for being here. Stay safe, stay sane, and have a great week.
Thanks, Nick.
Thanks.
Good to see everybody.
Goodbye, everybody.
Thanks, everybody.
Bye.